Hi, everybody. It's lovely to be here. So as HM said, I'm a psychotherapist in private practice. I'm from Canada. That's where I live. And so I'm focused on the legal and ethical aspects in Canada around legalizing psychedelic-assisted therapy. So while that's the context, I think that there's some issues that are transferable. I'd like to acknowledge and thank the Ohlone people whose ancestral lands we're gathered on today. I recognize their rights and title and that they may have never given their lands away. And I hope that they can preserve their sacred burying ground from further development. I've long been interested in the ethical issues around psychedelic science. I've talked about and written about issues for the last 10 years, and I want to thank the Women's Visionary Council for supporting my work and research. This is a really special place to be, especially for me. It fills me up. That's why I come here all the way from Canada. And so I'd like to also acknowledge the work and mentorship of Dr. Bruce Tobin. This presentation is a summary of his paper, Communicating with Clients about the Therapeutic Use of Psychedelic Medicines. And I'd also like to thank my many teachers, mentors, and colleagues and friends who've enhanced my knowledge and understanding of psychedelics and psychotherapy. Mariah Moser, Maria Mangini, Kathleen Harrison, Annie Harrison, Carolyn Garcia, Diana Slattery, Susan Boyd, Cynthia Palmer, Sarah Lipset, Jane Straight. Is it so amazing? I so honor and respect you. I don't know anyone else like you who brings plants to every gathering and gives them away. Like, you're a very, very special person. Yeah. And so while the information that I'm presenting today is not original, it's not my work, it's Dr. Tobin's work, I feel that it's very important to present it and to share it with us. I'm just curious, how many people in the audience are therapists? Oh, okay, great. There's a good number here. That's excellent. And so, of course, there's many underground ceremonies happening, and it's a topic that I've written about in the past, but this is really above ground professional work that I'll be discussing today. There's an increasing amount of literature that suggests currently illegal psychedelic drugs have potential psychotherapeutic agency. And as a result of media coverage, clients are going to come to us as therapists, and probably already have, asking us to provide therapy for them. And as therapists, our clinical competence is evident when we have a good general understanding of current psychopharmacological approaches, as well as experimental emerging treatments as well. And some clinicians believe in the promise of psychedelic medicine, and they want to support the accessibility that can be defended, and then also improve the health outcomes of their patients. So that's really what we're going to be talking about today. And as therapists, we need to be aware of the potential risks, benefits, and applications of psychedelics to be able to discuss them. However, it's beyond the scope of this presentation to talk about the efficacy or the merits or the safety of psychedelic-assisted psychotherapy. It's something that I'm foregoing and taking as a given that people in the audience have some understanding about that topic. So this presentation will suggest some verbal messaging that therapists can give to clients, and I will also review the legality of providing psychedelic-assisted psychotherapy in Canada. And again, I feel like some of this is transferable to the US. So to what extent can clinicians legally and ethically tolerate, cooperate with, condone, or promote client interest in, or therapeutic use of psychedelics? What specific responses or messages should we be giving clients in situations involving their interest in or medicinal use of psychedelics? And are there circumstances, bless you, under which psychedelic-assisted psychotherapy can be conducted in an ethically and legally defensible way? So these are important questions that they bring up for therapists, especially those who believe in the merits of psychedelic-assisted psychotherapy. And like I mentioned, clients are going to be asking for this information, and this is where we encounter the legal and ethical issues. So a well-respected clinician and a well-read clinician who understands the therapeutic aspects of this kind of therapy might come to believe it's in a client's best interest, especially if there's dire need. And this is the way that dire need is defined. A client's distress is chronic, serious, and debilitating. The client has not responded well to orthodox behavioral, cognitive, psychodynamic, or other non-pharmacological treatment approaches. The range of conventional medicines has been tried and proven unhelpful or has intolerable side effects. Or the client is facing end-of-life issues and consideration of the long-term risks are not relevant. So psychotherapists should begin any discussion of psychedelics with the client with two general declarations, and these are very important. Message number one, and I'm going to go through a bunch of messages, but these are the first two that are of primary importance. Psychedelic medicines are illegal to sell or possess. As your therapist, I do not and cannot advise, encourage, or recommend that you engage in any illegal behavior. And message number two, as a psychotherapist, I'm not licensed to practice medicine. In particular, I cannot prescribe any drug, legal or otherwise. Please understand that I am not ever ethically or legally able to suggest, recommend, encourage, or advise you to take any drug, legal or not. So if a client discloses that she is considering using psychedelics therapeutically and is seeking her therapist's opinion, these two messages need to be shared. And civil and criminal liability can result if these two messages are not delivered. A person can be convicted of an offense even if they did not engage directly in illegal conduct. And so Section 21 of the Canadian Criminal Code refers to aiding or abetting, and it's defined as doing, or in some cases omitting to do, something that assists or encourages the perpetrator to commit the offense. So what can a psychotherapist say in addition to these two messages? And as therapists, even though we can't prescribe medication, we can express a positive attitude towards medication and direct clients to psychiatrists or physicians who can fully inform them about medicine and perhaps even prescribe it. So although we can't communicate, or we can communicate that we can't prescribe drugs, we can ethically share with clients our general clinical understanding of research results and steer them towards factual information. So I'm not a huge fan of antidepressants, just so you know, but in his paper, Bruce gives this example around antidepressants. So in a scenario where a patient may come to see you and asks about antidepressants, and you could say to them something to the effect of, you know, Susan, you and I agree that you're suffering from a serious clinical depression, and research shows that many clinically depressed people benefit from taking a prescription antidepressant medication. I cannot prescribe the medication, but I invite you to read some relevant literature that I'd like to give you on the benefits of antidepressants, as well as their risks and downsides. So this is message number 3. In response to your question about therapeutic psychedelic use, I acknowledge that yes, there's a significant body of literature based on clinical anecdote and formal research that indicates that psychedelics could be helpful to persons suffering from your symptom profile. And there may be some occasions that therapists will believe that they have reasonable evidence that a psychedelic is suitable for a client's condition and have confidence that the client can follow the structure during a session and a plan of psychotherapy following that session. And this message follows the previous ones, 1 and 2, with a simple statement of fact about the literature. So this is the next message, message number 4. Psychedelics appear to be very helpful in some situations, but also carry the risk of creating anxiety, disorientation, or confusion unless used in clinically appropriate circumstances and supervised by a trained therapist. They should not be used alone or without clinical supervision or proper aftercare. A careful and responsible therapist will want to especially underscore the risk factors involved in this kind of therapy. Now the therapist could go on and deliver messages 5 through 7. And these kinds of messages that I'm talking about could be easily transferable to something like cannabis. So message number 5, though I cannot recommend that you use the drug, I do encourage you to educate yourself about both the merits and the risks of psychedelic use for your issues. I'm willing to give you a well-balanced reading list that I believe will help you in your education about psychedelics. When you have read this material, I will be willing to discuss it with you, to assist you in understanding it, and to answer any questions you might have about it. So these messages fall short of recommending psychedelic use and encouraging clients to educate themselves about these kinds of materials. Not only do we need to talk about the risks, we also need to talk about the possible benefits. And messages 6 and 7 in particular support the client's ability to make an informed decision, though this also depends on the clinician being sufficiently familiar with the relevant literature. Message number 8. The use of psychedelics for therapeutic purposes is still a contentious issue politically and medically. You will encounter disagreement among authors and among professionals. The bottom line is that you will make up your own mind about its possible benefits, and you will make your own decisions respecting use accordingly. So this is somewhat of a philosophical statement, but it's still an important one. And this message comes from the current BCACC, which is the BC Association for Clinical Counselors, Code of Ethical Conduct, and Principle 2-3 states to practice the principle of responsible caring, registered clinical counselors will respect the abilities of individuals to make decisions on their own behalf. And this message says that the individual has the right and the responsibility to decide what is best for themselves. This message supports self-efficacy and self-responsibility and can be a sign of profound respect for our client. It's to be noted, though, that this message will depend on the age of the client, their developmental and cognitive abilities, and assumes that they're an adult who can understand information and make rational decisions as a result. Message number 9. I understand and respect that you've come to your decision to use a psychedelic medicinally, even though it's not a decision that I am able to recommend. In a further point in the conversation with the client indicates that they've come to a decision to try therapeutic use, and then you can deliver this message. And again, this message demonstrates respect for the client's autonomy, but it stops short of condoning the illegal behavior and does not contradict or detract from the first 2 messages. And so all of these messages demonstrate acceptance and respect for a client's autonomy, decision, and behavior without implying outright agreement with it. And it's important that the counselor's paralinguistic messages are in alignment with the verbal messages. So, when you say that these drugs are illegal, you can't be like wink, wink, nudge, nudge. The delivery of the message has to be considered ethical also. And here, the counselor is willing to encourage the client in crisis to explore something there is reason to believe might be helpful. And the question whether the client uses psychedelics involves moral and legal reasoning, as well as empirical information. So other examples of these kinds of situations are when a client comes and wants to talk about whether they should get an abortion or not, whether to leave one's spouse of 40 years, whether to confess an affair that you've had on the weekend, These are all the kinds of deliberations that fall in line with the one that we're speaking of right now. And is it permissible for the therapist to raise the subject of psychedelic-assisted psychotherapy? And here, the therapist believes that a psychedelic would benefit the client, but the client does not raise the subject. Here, let's imagine that it's the therapist who introduces the subject. There will be some occasions when our client is unaware of or negatively exposed to antidepressants, like I mentioned before, where it will be our ethical duty to strongly urge clients to take an antidepressant. We need to raise the subject and to acquaint the client with an option to be considered along with the others. And as long as we have clearly delivered messages 1 and 2, we may follow with 3 through 9, even though we have initiated the discussion of psychedelics. There's an ethical aspect of the therapist's competence to supervise the session. So let's look at a radical situation that appears to outright support the client's psychedelic use, where the clinician participates as a therapist in a client's psychedelic session. So section 2.2-7 of the BC ACC Code of Clinical Ethical Conduct states that a counselor will limit their practice to the areas of competence in which proficiency has been gained through education, training, or experience. Counselors are able to gain competency in psychedelic psychotherapy. There's a substantial training literature, and there's also training opportunities for people to learn about how to do this. So the training programs, MAPS has an expanded access training program right now. CIAS has a certificate in psychedelic-assisted therapies and research. There's a lot of reading to be done. Stan Groff has a book called LSD Psychotherapy. There's training manuals like the MAPS, PTSD, MDMA training manual, and Janice Phelps has a great paper called Developing Guidelines and Competencies for the Training of Psychedelic Therapists, and that's a highly recommended paper. So message number 10. Yes, I consent to attend your session and provide psychotherapy to you while and after you are under the influence of a psychedelic. How might this message and the supervision of a psychedelic session be assessed from a legal perspective? What is the legal exposure for the therapist? So let's consider a scenario for a moment where a counselor is working in an emergency room of a hospital, and Alice, age 27, comes into the emerge, and she's suffering from a bad trip. She's taken an unknown amount of LSD and is suffering acute panic, paranoia, and confusion. She's been brought to the emergency ward by a police officer after responding to a noise complaint about a loud house party. Alice arrives screaming and crying, insisting she is dying and that everything is melting. She reports visions of being chased by evil beings. And the skilled clinician that's there quickly finds her a quiet, private room and lowers the lighting, puts on some soothing music, and invites Alice to wrap up in a nice cozy blanket on a couch and close her eyes. She remains with Alice, encouraging her occasionally to pay attention to her breathing and just follow it wherever it wants to go. Alice undergoes several deep emotional experiences involving intense hostility towards a family member and then grief involving deep sobbing. Later, as Alice calms, the therapist enters into a quiet therapeutic conversation with her about her experiences. Alice gradually settles into a peaceful state in which she reflects on herself, her current relationships, and what is most important in her life. And hours later, she falls asleep. So here, the counselor promoted a drug-affected client's mental health interests as humanely and as helpfully as possible. And in this situation, it was legally permissible because there's no Canadian law prohibiting a professional from assisting a drug-affected client. It could be argued that assisting a client in the clinic is no more radical than helping a client in a drug-affected state in the hospital. Both share the same legal status, right? It might be more legally permissible helping a client in the hospital because the therapist had no role in the client taking the drug, as this happened before the client came to the emergency room and met the therapist. So psychedelic therapists may therefore seek to bolster the legitimacy of message 10 with the following caveats. I cannot and will not supply a psychedelic to you, nor will I administer it to you. I cannot and will not be present when you ingest it. I require you to sign a statement just prior to the session that acknowledges that I have indeed clearly delivered messages 1 through 9 and that I have complied with the above. These statements effectively build a firewall between attending the session and any complicity in the client's coming to use the psychedelic. Therapists cannot participate in the procurement of a psychedelic or the decision to use it to avoid charges of trafficking, possession, or aiding and abetting possession. By making sure of these things, there is a closer alignment between the hospital scenario that I just spoke about and the therapist providing therapy outside the hospital. In both cases, the therapist has special clinical expertise to assist a drug-affected client so to maximize the client's interests and reduce harm by providing safety and competent clinical intervention. This is a form that Bruce has in the appendix of his paper. It's a client declaration form that he suggests that clients sign before the session starts. And again, you can find it in his paper. I'll leave it up here just for a moment so you can see it. So, can this position be challenged in a court of law or an ethics committee of a professional association? What legal precedents might be relevant to a defense? Unfortunately, a promising defense of the therapist's participation in providing support in a psychedelic-assisted therapy session stems from the Canadian Charter of Rights and Freedoms in Section 7 that guarantees that everyone has the right to life, liberty, and security of person. This has been interpreted by Canadian courts as implying that a citizen has the right to personal autonomy in making healthcare decisions and the right to be free from criminal prohibitions or unduly restricted regulatory schemes interfering with that medical autonomy. In this regard, 3 court cases appear relevant, and I'm just going to briefly, very briefly, summarize each one. So first, in R versus Parker, R is Regina, the Crown. This is from 2000. The Ontario Court of Appeal affirmed the right of Canadians to access an illegal substance, cannabis, for the treatment of an illness in situations when there were no effective conventional treatment alternatives. This led the court to order access to cannabis for certain patients through the Marijuana for Medical Purposes Regulations, MMPR, which is now somewhat obsolete because we have a Cannabis Act. The second case is R versus Smith in 2015, which affirmed the right of medical cannabis users to access non-smokable forms of cannabis, like edibles, tinctures, salves, as well as the smokable forms available through MMPR. The Supreme Court of Canada ruled that the prohibition of non-smokable forms of cannabis limits the liberty of medical users by foreclosing reasonable medical choices through the threat of criminal prosecution. And the last one, similarly, by forcing a person to choose between a legal but inadequate treatment and an illegal but more effective one, the law also infringes security of the person. Most recently, Allard versus Canada in 2016, the same charter-based reasoning led the federal court to rule that approved medical cannabis users could legally grow their own cannabis as an alternative to purchasing it from the government-approved licensed producers. So there's parallels between the Parker, Smith, Allard cases that I just talked about and therapists consenting to supervise a client's psychedelic session. The extent that a client's psychological condition is not amenable to current orthodox treatments, and to the extent it can be shown that psychedelic-assisted psychotherapy is a reasonable medical choice, we could use the reasoning under Parker, Smith, and Allard to argue that the client has a charter-based entitlement to a constitutional exemption to the criminal code provisions respecting psychedelics, and that the federal court should order that the current law against possession of a psychedelic be modified to allow medical use. So something along the lines of psychedelics for medical purposes regulation instead of just cannabis. Since with such an exemption, the client could not be charged with possession of a psychedelic, the clinician would be protected from a charge of aiding and abetting and of being party to a psychedelic possession. We might also argue, based on Parker, the justification for providing a psychotherapeutic service stems from the same recognition of the client's right to make healthcare decisions that led MMPR to provide a substance. So all of these examples I've just spoken about are about a substance. Let's now talk about legitimacy of provision of a service rather than a substance. So a recent Supreme Court decision may also be helpful in the defense of Message 10 and psychedelic-assisted psychotherapy, as it legitimizes the provision of a service rather than a substance. The right to healthcare autonomy from Section 7 of the Charter of Rights and Freedoms served as the basis for the 2011 Supreme Court decision to uphold Vancouver's safe injection program, which is called Insight. This decision allows healthcare practitioners to supervise injections of heroin, fentanyl, whatever it is that people want to inject into themselves, to minimize risk and prevent overdoses. The court ruled that Insight's client's charter right to life, liberty, and security of the person would be denied to them if clinical supervision of their injections was denied. So the parallels between Insight and supervising a session appear compelling. Just as medical supervision of an addict's injection of a street drug reduces the risk of infection, so supervision of a psychedelic experience reduces risk of a bad trip or a counterproductive session. The services desired in each case by the client are healthcare services that contribute to harm reduction. The clinician's supervision of a psychedelic session honors the client's right to healthcare autonomy. The therapist's supervision of a psychedelic session, therefore, just as professionally defensible as the nurse's supervision of an Insight client's injection of a drug they have no role whatsoever in providing in. And if the Insight parallel holds, clients coming to their psychedelic session should have no need to fear arrest for possession of a psychedelic. The Insight argument would protect both the psychotherapist and the client. So most Canadians agree that it's in the public interest that crisis intervention counselors are available at mental health facilities to deal with individuals who often make impulsive and sometimes irresponsible drug choices about what they take and where they take it. They agree that even those citizens are entitled to the provision of emergency mental health services. But medical psychedelic clients see themselves as eminently responsible users who, want to use psychedelics according to the research with clinical protocols and session supervision that's indicated in the protocols. So the previous arguments based on the charter and on the parallels between supervising a session and Parker, Smith, Allard, and the Insight example indicate that psychedelic-assisted psychotherapy could, under limited circumstances, be considered both ethically and legally defensible. Both the ethical and the legal cases would appear strongest when the involving clients who are desperate and in dire need would intend to use a psychedelic with or without the therapist. And the case is weakest when it involves less desperate clients who would be deterred if they did not have clinical supervision. But even under the most favorable circumstances, legal defensibility is challenging. A court case for medical psychedelic use could go forward like this. The clinician would perform the psychedelic therapy service. He or she would then be arrested, charged with aiding and or abetting client possession of a psychedelic and found guilty. An exoneration would come only on appeal, likely at the Supreme Court level, in the event that the court saw fit to grant a constitutional exemption for the client and the therapist along the lines of the cited cases. And in practice, the law is rarely clear until push comes to shove. And though a charter defense seems possible, counselors should not be encouraged to go down this road unless they have a willingness to face all possible consequences. The ideal legal clarity we desire for a basis for practice will come only from future court rulings that we can't fully predict right now. And as a result, clinicians will experience, on one hand, a tension between, an ethically based desire to mitigate their client's suffering, and on the other hand, a practical desire to protect themselves from legal risk. Ethical reasoning is ultimately a personal process that guides our practice. The best outcomes result from sound reasoning and fundamental ethical principles, not from following group consensus or authority for its own sake. Some ethical decisions will not require consultation because they're so clear and straightforward from the very beginning. But scenarios such as providing therapy may involve difficult and higher risk decisions, and the risk of doing harm is higher. There may be genuine room for disagreement about the client's interests or how to best serve them, and there may be more than one approach that can genuinely be considered ethical. Here, collegial collaboration in the ethical reasoning process is crucial, and two additional considerations support this view. The first one is that solitary ethical reasoners may not know what they don't know, and you don't know when you're missing an important piece of the ethical picture under consideration, a piece that others, especially those familiar with some similar situation, may easily see and point out. Second, solitary reasoners can't easily know when they're falling into self-deception, when their interpretations of clinical facts or ethical principles and conclusions are being swayed by factors such as personal desires, needs, motivations, or emotions that they're not aware of, factors that others might clearly see and point out to them. So while the decision is ours to make, it's ideally made within a relational context of clinical supervision or peer consultation. We want to do our best and not overlook something in making our decision. It's important to pay attention to our reluctance or our resistance to engage in this relational aspect of ethical reasoning as a hint that, maybe our solitary reasoning process may not be sound. So that's something to pay attention to. So a second course of legal action is far more preferable to the therapist, becoming charged as a defendant in a criminal possession case. With this option, the therapist avoids all risk of legal or ethical censure. Here, the therapist, not the Crown, would initiate the legal action. So prior to providing psychedelic psychotherapy, the therapist would begin by petitioning the federal government on behalf of a well-chosen specific client for a medical exemption to the criminal code provisions for possession of a psychedelic. And when the petition is denied, the therapist would then sue the federal government in court on the grounds that the prohibition of possession for medical purposes contravenes the provision of the charter. And so this approach transforms the focus of the case from being about a criminal defense of a therapist to being about the patient's human rights. And there's another possible legal outcome to using charter-based arguments for those in dire need. Canadians now have a legally recognized right to die legislation called MAID, it's Medical Assistance in Dying. And approved patients, it took a long time to get there. Approved patients in dire medical straits have the right to take drugs that will kill them. And Bruce Tobin, who wrote this paper, he has an initiative called Therasil that you could find online, and it advocates for a right to try by obtaining legal access to experimental drugs that offer hope and relief for desperate clients. And I believe that many American states also have right to try legislation that allow terminally ill to use drugs that show positive results in phase 1 and 2 but haven't been tried in phase 3. Health Canada has a special access program that allows practitioners treating patients with serious or life-threatening conditions to request access to drugs unavailable in Canada when conventional treatments have failed, are unsuitable, or unavailable. But that special access is limited. Certain restricted drugs, including psychedelics, are not available. And so we're trying to change the special access criteria. We'll see how that goes. So I've tried to give you an overview of how to answer these questions and providing information about the ethical and legal implications involved in psychedelic-assisted psychotherapy. I'm sympathetic with those who believe there's sufficient substance in research literature to validate optimism that currently illegal psychedelics have an important role to play in clinical treatment strategies. But the tone is cautionary. Even when we have sympathy with the medical merits of psychedelics, let's be clear and careful with our messaging. The agenda for advancing the availability of psychedelic medicine in Canada will best be realized when our professional conduct remains within ethical and legal limits. I hope that the legal environment will change so that psychedelic-assisted psychotherapy will be viewed as a legal and efficacious treatment modality accepted by mainstream medicine and clinical practice. Thank you for your time.
Do you feel like you could take a couple of questions?
Yeah, sure.
Okay. Just like probably two.
Yeah.
Hi, that was a wonderful presentation. Thank you. Can you hear me? Yeah. So I'm wondering how much the cases that you cited might be applicable to the U.S., where we're also supposed to have life, liberty, and the pursuit of happiness. I don't know about some kind of health right that is enshrined in our Constitution, but we at least have that. So do you know anything about any U.S. cases or any correlation?
Unfortunately, I am uneducated about the U.S. law system, but those cases were actively pursued to get the Cannabis Act, which we have now, which makes cannabis legal in our country. So that was a huge change, and maybe that, those kinds of arguments could be used in the U.S. as well to make that happen.
Thank you. That was really phenomenal. Thank you so much, especially with kind of decrim happening here in Oakland. It just has my brain thinking a lot. Two specific questions. One is just clarifying, can we actually educate the client that if we were to go through all these messages, there could be the opportunity for us to do this together, or does it have to kind of entirely organically evolve on its own?
Well, I went over that in terms of, what if the client comes to you asking for these things, and you have to start by those first two messages that, are so important. And I believe that those messages have been posted online next to my bio for the schedule about how to say it and when to say it. And we can also suggest to a client, it's our ethical duty to give them options among other treatment modalities that they may consider, as long as we provide adequate evidence and encourage them to also explore the evidence. So it's a well-educated decision that is really theirs to make.
Perfect. Thank you for clarifying. And then my other question real quick was just that I've read in other articles that to just better for the therapist and defense from their perspective, to get further formal training in harm reduction, so that if somebody were to approach you, you can say, I've actually been trained to do harm reduction work with clients. Would you say that that would be a good avenue to further support yourself?
Yeah, and not only harm reduction, but benefit maximization. How are clients going to get the most benefit from their session? And again, that is based on your clinical proficiency in this area. And like I mentioned, that in our code for conduct, we need to be proficient in any treatment modality that we're offering. If we didn't, then we'd be working out of our scope, which is clearly a no-no. So I think it's good for therapists who want to do this work to gain proficiency, professional proficiency in this area.